Hey, my name is Yev. Thank you so much for coming to today's presentation. The title of my talk is The Good, the Bad, and the Ugly Case-Based Updates on Transfusion Reactions for Enugu, Nigeria. Um, I'm gonna wait a bit for everyone to get into the Zoom room. While everyone is coming in, I'll just leave the disclosures up here. Great, let's keep going. So, one of the disclosures where I put the heart is that the slides contain text for later reference. I won't be reading from the slides. I'll be just touching on some key concepts as we move through this PowerPoint, and they'll be provided for your later review. Please put questions in the chat, and we will go through as many as we can at the end. And thank you again for having me here presenting. This is absolutely lovely to be here, and it is an honor to present to this audience. Thank you kindly. So let's talk about the good, the bad, and the ugly. What does it mean in the context to Enugu, resource-constrained blood system and its priorities? The good is that transfusion saves lives of patients who need it most, and those include sickle cell patients, OB patients. Enugu has nascent hemovigilance efforts by National Blood Service Agency and BSA, which is Nigeria's hemovigilance agency. The bad is that the acute transfusion reaction rates in sub-Saharan Africa are 6 to 14 times greater than USA and Europe. And the numbers are there for the comparison. And the ugly is that 14% of acute transfusion reactions are life-threatening and 1% is fatal. And those, despite it being just 1%, is a very high number. The outline for the lecture is as follows. We'll talk about some pre-lecture questions, talk about transfusion reaction definition, the diagnostic criteria for those reactions, and the general symptoms to look out for, the components of a typical transfusion reaction workup, and the 6 transfusion reaction cases, presentation, diagnosis, and management. Don't memorize the slide. Don't memorize each slide. The goal really here is to diagnose efficiently, stop the transfusion when needed, protect the patient, know which workup is worth doing, prevent future reactions when possible, and keep in mind that I appreciate that the transfusion system in Nigeria is very different from what it is in the United States, and especially in University of Washington. But I will try to include literature that is reflective of Nigeria throughout this presentation, and also some local pictures, because Nigeria is a beautiful country. Answers will be revealed during the presentations. You all received these questions beforehand, so you should have access to them. Thank you. So, transfusion reaction definition is really any unfavorable or unintended or adverse event occurring during or after transfusion of blood or blood products. A lot of my references will be in the bottom left corner for your later review and study. Thank you. There's many ways to diagnose transfusion reactions, but it's best to have a standardized approach. The biovigilance component hemovigilance module released by the CDC is a pretty sweet guide. It's only 35 pages. The Transfusion Reactions book is a little deeper. It's a great reference. It's about 700 pages, but up to date is infinite pages. And if you're not reading up to date, you should. It's awesome. Basic transfusion reaction symptoms, they're just here for you to get an appreciation depending on the transfusion reaction symptoms. The reaction could be hemolytic, febrile non-hemolytic, allergic, or septic. And we will go through these as we move through the talk. The typical transfusion reaction workup really includes not that many things. It's really like three things, but it could be five things. Again, this all is institutionally dependent, but for you, could be a clerical check, a BORH, and a pre and post transfusion sample. It's a visual hemolysis check. Visual hemolysis check should always be included in the reaction workup because it's easy, and so are the other ones. DAT should be included, and again, alloid compatibility testing and hemolysis labs. They are really not part of the typical protocol, but when needed, they can be included in the workup of a transfusion reaction. The AFSBT has a lovely hemovigilance interface. It's here for your reference. It's page 30. Its effective date, it's been around since about 2014. So it's a nice document. And there's also, they list exactly what they use and recommend for transfusion, adverse transfusion events listed in the 9.1.1. So question number one, here's your answer. From symptoms to differential, let's construct a 2x2 matrix. And we have fever and we have hemolysis on both axes. And then we have no fever and no hemolysis on the other axes. These are the reactions in green that we're going to cover throughout the presentation. And you can see if there's a fever and if there's a hemolysis, you really only have two choices. It should be really straightforward. And if there is a fever and no hemolysis, you really only have four choices. And when you look at epidemiology and statistics, FNHCR is usually the most likely diagnosis, but that's not to say that other reactions don't happen. I've seen my share of septic and trolley reactions, and there's going to be probably more in the future that I will diagnose. And it's important to keep that at the back of your mind when you're working through these cases, because knowing when to identify them helps save lives. No fever, no hemolysis, that's where majority of the reactions actually live. And here we will cover only the ones highlighted in green. So for this case, I'm gonna stop talking for 60 seconds. I'll let you read it in your head and then answer the question at the end. Thank you. Great. Time is up. Let's move forward. So based on our presentation, we have no fever, no hemolysis, no respiratory distress, blood pressure and the remainder of the vitals are stable, and timing is about 30 minutes into transfusion. The post-transfusion sample is negative for hemolysis, and our diagnosis here is an allergic transfusion reaction. When we look at the CDC criteria, it hits those check boxes highlighted by the green arrows. And that is really here for you to appreciate that the CDC criteria can be quite dense, but it's really nice criteria, and I really appreciate it. And there's other criteria out there, but I like the CDC. So case one, the diagnosis is allergic reaction, but what's the incidence of allergic reactions in sub-Saharan Africa? Febrile non-hemolytic reactions and allergic reactions make up most reactions in sub-Saharan Africa. The recommendations for further transfusion in a mild allergic reaction Again, in a mild allergic reaction, give histamines like diphenhydramine. You can wait for symptoms to resolve, and then you can continue transfusion of the same unit. When there's a more serious adverse event, stop the transfusion. I appreciate that different practices don't want to stop the transfusion, but here we stop the transfusion. Case 1 management. Here's the answer to your second question. Do we perform a DAT in the case of reaction in which hives and itchiness is the only sign and symptom? Generally, no. DAT detects antibodies or complement, which is coded on the red blood cells, and we're not expected to see those in an allergic reaction. The mechanism of an allergic reaction is different. Its donor plasma is reacting with recipient antibodies like IgE, and the recipient IgE on mast cells causes activation, degranulation, and the release of histamine and adenosine. So the basic management of allergic reaction is we can, again, just give medication after it occurs, like with antihistamine, diphenhydramine, cetirizine, famotidine, and provide supportive care when needed. I enjoy pictures of nature. I think nature is really cool. I like the outdoors. Um, on the right is a beautiful Cross River National Park in Nigeria, and if you see, it has these beautiful rainforest trees that are growing on a nurse log, or there was a nurse log there. And on the left side, we have the whole rainforest in West Seattle, and we have a nurse log there as well. They're both it's, if you're interested in going there, it's about like a 6 hour drive from Enugu. Um, that's right. Yeah, it's about a 6 hour drive. But yeah, very beautiful. Let's go on to case number 2. I'm going to pause here for 60 seconds and let you read in your head, and then we'll proceed with answering the question. Thank you. Great. It's been about a minute. Let's keep going. So the patient here had no fever, no hemolysis. They had mucocutaneous manifestation, but then they also developed hypotension, tongue swelling, dyspnea, and throat tightness and cough. And the diagnosis here is an anaphylactic reaction. The CDC criteria for anaphylactic reaction is as follows. It is highlighted there for you on the slide, where we saw hypotension, pruritus, hives, urticaria, and there's also anaphylaxis when, in addition to mucocutaneous symptoms, you have airway symptoms, hypotension, and cardiovascular collapse. Um, the criteria, it needs to occur within 2 hours of cessation of transfusion. That is the definitive criteria. Now, keep in mind with all of this, like we also have to consider what's going on with the patient. Therefore, I'm only giving you like very easy cases of definitive diagnoses. The Oftentimes this is great for boards world and for like test taking. Real life can be a little bit different because they can have anaphylaxis to something else that they recently had in their system, like a new antibiotic. But I just want to highlight that for just a moment to say that this may seem very easy and straightforward, but on a day-to-day practice, it gets a little bit, there's more finesse to it. But generally, the definitive criteria is that it occurs within 2 hours, and if it occurs after 2 hours, it's probably related to something else. Possible if it's occurred 2 to 4 hours after the transfusion. The management of suspected anaphylactic reaction, the algorithm here is from up to date. It's my own take on the algorithm, so I just kind of put it in this flow chart. If you suspect anaphylaxis, the first immediate intra line treatment is you give intramuscular epinephrine in the mid outer thigh, and the doses are there, and they're also up to date. If the patient is improving after you reassess response and you can give more doses, you can just continue monitoring and provide supportive care. But if the patient develops severe and refractory reaction impending in cardiovascular collapse and despite intramuscular epinephrine, you should you should give slow IV epinephrine bolus to monitor with the hemodynamic instability. 5 and 6 tell you additional supportive therapies as needed, post-reaction lab evaluation as needed, and let's move on to our next case. So our case 3 presentation, and I'll give you 60 seconds to read this in your head, and then we'll answer the question. Great, time's up. So using our 2 by 2 matrix, we have a fever in this case, but we also do not have any hemolysis, and that puts us in this quadrant highlighted in green. And the patient, developed those symptoms, and initially it went from 37 to 38.5, but 6 hours later they developed very high fever, violent rigors, nausea, tachycardia, vomiting, and hypotension. So you could see how a febrile reaction can very easily become a septic reaction or a reaction known as a transfusion transmitted infection reaction per the CDC. Let's work with the easy one, the febrile non-hemolytic transfusion reaction. This one is straightforward. It's within 4 hours. We have a fever that is greater than 38 and a change of at least 1 Celsius from the pre-transfusion value. But you actually don't even need any of that. You can have chills and rigors present and you're done. Um, it's that's the easy way to diagnose these. But sometimes that's not there. Yeah, so initially it looks like febrile non-hemolytic transfusion reaction. What do we do with these? These are benign. However, they're still very important to rule out as a first reaction because there could be many other things underneath that we need to consider. And when you diagnose a febrile, I'm gonna just take a quick tangent here. When you diagnose an FNHTR, you should not stop there. You should keep going because you should be like, okay, I've diagnosed this. What is lying underneath? A similar concept occurs in hepatocellular pathology and liver pathology, where you can diagnose one diagnosis, but there's always underlying diagnoses underneath, many, many layers. So it's important not to stop there, but to keep going and going. But if you don't find anything and you rule all the other reactions out, it's a febrile non-hemolytic transfusion reaction until proven otherwise. So you stop the transfusion, you rule out, you administer antipyretics like acetaminophen. You can give meperidine if the patient has severe chills or rigors, and if the patient is having a very high fever, or you are suspicious that they have a small fever but they could have an infection underneath, it's considered to have a high likelihood of infection, like they're the sickle cell patient, or I'm sorry, let me say that, let me dial that back. They're receiving immunosuppressive therapy, or they have functional asplenia from sickle cell disease, because those patients, a small fever in that context can be um, something more serious. So it's important to consider the entire patient as you're working these cases up. Those patients, if you're concerned about them, they will get admitted to the hospital, go into the ED. Case 3, differential diagnosis. Let's continue this. So initially it looked like an FNHTR, but 6 hours later the patient developed a high fever of 40 Celsius, violent rigors, nausea, tachycardia, vomiting, and hypotension. So this is answering your question number 3 that you received before. What is your criteria to send the remnant of a unit associated with a febrile reaction to for bacterial culture? There is no hard criteria out there, but generally the criteria that I like to see is high fever, tachycardia, hypotension, something more than a febrile FNHTR. And these have to be significant. You have to be quite suspicious that the unit was contaminated. And usually there's more information other than this. It's not just these 3 symptoms, there's more. But for basics, these 3 symptoms will be helpful. Case 3 lab diagnosis of a TTI septic reaction is you want to do a gram stain on the residual blood product. It's rapid, it's easy, it's available at most labs. So it's a very basic lab test. Blood cultures, like you want to culture the patient and the bag. You want to make sure you get 2 cultures from the patient as well. And then labs, you get a CBC, like a renal function panel, because you are concerned for the kidneys. And you also look for a coagulation screen like PT, PTT, INR, fibrinogen. You also want to rule out an acute hemolytic transfusion reaction by visual check. You should do a visual check on any transfusion reaction workup because it's very easy. It's just you just look at it. It takes not even a second. And it helps to provide a correct diagnosis for patient care. Case 3 lab workup of a TTI results. So for this case, the gram stain of the residual product was gram positive cocci. The patient blood cultures, we got 2 sets from the patient and 1 from the bag. They grew Staphylococcus species like coagulase negative staph and Staphylococcus aureus, which could be common contaminants because they're skin flora. We also have a CBC renal function and coag screen, which shows that we have leukocytosis, thrombocytopenia, urine output is normal, PTT is elevated, and fibrinogen is low. So the hemolysis check here is negative, which is great. The diagnostic criteria for TTI septic per the CDC is listed here for your review. In this case, it is definitive because we have lab evidence, and we meet the criteria for severe. Patient is hospitalized, and in this case, and definitive because we have evidence of the pathogen in the transfused component, and there's no other potential exposures to the pathogen that could be identified in the recipient. So in this case, the patient got the transfusion, and we can't really make the case that the patient already had an infection or didn't have an infection or got it from something else. So whole blood in this case is the only source. The immediate management of a transfusion reaction is number 1, you stop the transfusion. That should be like your number 1 goal. Stop the transfusion. You maintain a patent IV line because you need to run supportive resuscitative care. You notify the blood bank immediately. Discuss the possibility that other patients may be affected because there could be sister units that we have in our inventory that we need to quarantine. So that's really critical to know. And save unused product and bag. You want to return that to the blood bank because we're going to culture that, and that should be done already. Well, sorry, that should be done because this is now the management of it. You want to rule out something that is more sinister, like an ABO incompatible hemolytic reaction, and you want to also give start antibiotic empiric therapy after the cultures are obtained based on the gram stain. We could start with vancomycin. It's a broad spectrum beta lactam, and then that should provide coverage for most likely gram positive and gram negative organisms. But when the culture results resolve, you can finesse the antibiotics to something more specific. Bacterial risk mitigation in African blood centers. So based on this survey of 40 that received 45 responses, it was from 16 countries, and all respondents were urban, 36 were blood centers. Nigeria is one of the respondents in this survey. You could see that they are doing an incredible job at doing skin disinfection, but skin disinfection is not enough. We need to do more diversion pouches, bacterial culture, pathogen reduction technology, and also point of release testing. The next best step for um, African countries that were mentioned in that survey is they are already ramping up their diversion pouch use. Diversion pouch is a very easy modification to reduce contamination due to bacterial skin flora in the transfused component because the first 10 mils just gets discarded. Here's a beautiful picture. It's the Zuma Rock. It's about a 6 hour drive, 7 hour drive north of Enugu. This one's taken by Vallecchio Olgli Joe, and you can see it's a gorgeous picture. Very beautiful. We have mountains in Seattle, but they're nowhere near as beautiful as this one. If you can really appreciate the structure of the mountain, it would be very challenging to climb. I wouldn't want to climb that at all, actually. But from this picture, it's very beautiful to look. Somebody more experienced than me can climb this mountain, but I'm more comfortable with smaller hills. Case 4 presentation. This is a 60 seconds to read in your head, and then we'll answer the question together. Great, let's answer the question together. So, so the diagnosis in this case, we had a fever and a hemolysis, okay, and then there's also severe back pain and fever to 40 Celsius, rigorous hypotension, blood pressure goes 50 over 80, I'm sorry, 80 over 50, and there is dark urine. The final diagnosis here is an acute hemolytic transfusion reaction. What is a differential, however, for an acute hemolytic transfusion reaction? It's not just a one and done kind of thing. There is different reasons for why there is acute hemolysis. In the context of Nigeria, there's a paper that reported that 32% of Southern Nigerian group O donors have very strong hemolysis. So O whole blood can have very high titer anti-A hemolysis. And the mechanism for this case is that the donor with an anti-A and B IgM and whole blood activates recipient complement, causes intravascular hemolysis. There's free hemoglobin and renal failure, DIC, and shock. The other differentials include ABO incompatible transfusion, which is like an identification clerical error. These are really, really bad. They should never happen. Ever. Ever. I'll repeat that. These should never happen. Ever. And we have a lot of processes and policies to prevent these from happening. There also is non-immune hemolysis. The blood could be overheated, the blood could be frozen and then thawed. There could be hypotonic solution that is run through the same line as the blood. These are uncommon. We don't like seeing these. No one likes seeing these. So, and it's bad for patient care. Like the patient doesn't want these, right? So, but in the context of this educational seminar, um, high titer anti-hemolysins in group of whole blood is what caused this ABO, acute hemolytic transfusion reaction. Case for diagnosis in this case is that it meets all of the criteria for an acute hemolytic transfusion reactions. We got back pain, chills, rigors, fever, hematuria, hypotension, decreased haptoglobin, elevated LDH, and plasma discoloration consistent with hemolysis. And there's also a positive direct antiglobulin test for this case. So the presentation in this case, it already meets the criteria based on the case presentation. We had back pain, chills, rigors, fever, hematuria, hypotension, decreased haptoglobin, elevated LDH, and in the next few slides we'll see plasma discoloration and C3 results. So here was the patient's plasma, and we can confirm, obviously, like, these cases are made up. You're looking at that, you're like, did you doubly have a hemolytic transfusion reaction? We didn't. This is just a different sample from something else, but this is what hemolysis would look like. And here's an example of hemolytic transfusion reaction, what you would expect in the sample. And then the patient in this case, the workup that you would do is you would confirm patient ABO/RH, you make sure they match the pre and post transfusion sample. You would do clerical check, and which was correct in this case. You sent the blood bag and the tubing back to the blood bank. You could see on the visual check, for example, that the sample is hemolyzed in the post transfusion samples. You would repeat the ABO/RH labs on the patient and the blood bag segment. Urinalysis, you would do urinalysis, CBC, CMP, hemolysis labs, and coagulation labs, and a peripheral smear. The DAT in this case is polyspecific. It was positive. IgG, for example, would be negative because the offending antibody is IgM, and the C3 would be positive. Sometimes in these cases, if there's like overt and brisk hemolysis, the DAT may be negative because all the cells would have already been hemolyzed. So don't let a negative DAT make you think that this is not a hemolytic transfusion reaction. Case for management. First step, stop the transfusion immediately. Maintain IV access with normal saline. You want to give aggressive fluid resuscitation. Furosemide, you give that to increase urine output and avoid if the patient's hypotensive. You can monitor for DIC if bleeding, transfuse compatible fresh blood, or components as available. You would monitor potassium, hyperkalemia from hemolysis. You treat if it's greater than 6. You could also give vasopressors if refractory, if there's refractory hypotension. Don't transfuse further until the blood bank has confirmed a new compatible unit. So what's the acute hemolytic transfusion reaction epidemiology in sub-Saharan Africa? They are only occurring in 4.8% of patients. This is based on a 2026 systematic and meta-review and meta-analysis of 26 studies in the sub-Saharan part of the continent, in which Nigeria is also included. So this is like kind of like a broad perspective. And the PMID is there for your reading and review. So in the previous picture, we saw a very beautiful mountain. Here is a very beautiful mountain from Seattle. As you can see, it's not as sharp on the edges. It's more of a peaked formation. So it's like peak. It's like peak formation, and there's glaciers there, which is incredible. And this is a really beautiful picture I want to share with you all. It was taken by Tal Senior, Mount Rainier National Park. Here is our case 5 presentation. I'm going to pause for 60 seconds and let everybody read the question. Great, all done. Let's move on to the differential and next steps. From symptoms to differential using our 2 by 2 matrix, you could see that there is hemolysis and there's a fever in this case. So we are already in the top left box. It's the box that really nobody wants to be in, but we are here. So let's figure out what's going on. The patient presents 8 days later, fever 38C and dark urine and a hemoglobin of 6.1. So they're hemolyzing, their hemoglobin is trending down, and it's a the dead giveaway here, the cat's out of the bag, is that this is 8 days later now. So that's what makes it delayed. Case 5 workup. We have the general workup that we already mentioned it, but once again we'll go over it. You do a visual inspection of a post-reaction sample, as shown on the right. The DAT in this case is positive. The polyspecific is positive because polyspecific tests IgG-C3. The case here is that its IgG is positive, so this is more of a delayed, slower hemolysis secondary to IgG. And if an antibody screen is performed, I understand that not every facility in Nigeria or the sub-Saharan Africa has access to an antibody screen, but let's pretend that we are working in an environment that has access to that technology. If the screen was performed, it is now positive, and it was negative or not performed during before the transfusion. The antibody identification is in this case anti-JKA, and eluate shows that anti-JKA is present and it's on the recipient red cell surface. The hemolysis labs in this case are high LDH, high indirect bilirubin, decreased haptoglobin, and decreased reticulocytes. So the hemolysis labs in this case would have high LDH, elevated total and indirect unconjugated bilirubin, and direct could be within normal limits. Haptoglobin and reticulocytes would be decreased. And there's an image on your right. The pathophysiology of a delayed hemolytic transfusion reaction is there's an initial exposure to the antigen, the plasma cells make antibodies, and then there's an evanescence. Then there's a secondary exposure, usually in the form of a red blood cell transfusion. This causes anamnestic response, and those plasma cells, memory B cells, those plasma cells generate antibodies, and they generate a lot of antibodies. They bind to red cells and cause extravascular hemolysis. So the case 5, delayed hemolytic transfusion reaction management. Case 5, so delayed hemolytic transfusion reaction management will be to monitor hemoglobin until hemolysis has resolved. The frequency of the labs should reflect the clinical severity. When mild and hemolysis is not brisk, you provide supportive care only. Escalate if ongoing brisk hemolysis occurs, such as falling hemoglobin, rising bili, absent haptoglobin, or hemoglobinuria. For brisk hemolysis, consult hematology and consider glucocorticoids, IVIG, or rituximab. And you also want to protect kidneys during active hemolysis. Hydrate if safe, monitor urine output, and avoid future red blood cell units carrying the implicated antigen. Here's another picture. This is from Cross River National Park. It's about a 9-hour drive from Enugu. Looks like it's a very dense rainforest, and I'm just leaving it here for you. This was taken by Gabriel team in 2019. Let's move on to our last case. I'm gonna give you a minute to read the slide and then we can proceed. Great. Time's up. Let's answer the question together. We also have imaging. Yep. Okay, yep. So in this case, there's also imaging. Patchy bicellary opacity suggests of aspiration or infection is here, but then opacity, there's also an opacity on the right parahilar region. That's concerning for pneumonia. But in addition to all of that, there's an interval development of diffuse interstitial edema. You could see it's a little bit kind of wider over here, and sometimes it's very subtle. We always love to see like kind of like a white outline because that's what we expect to see. Sometimes it's incredibly subtle and it's not always there. And sometimes you just gotta go down and talk to radiology and call to radiology to have them go over the scan with you. That doesn't happen that often, but it's just important to know who to call for these cases. Um, Great. So let's go to the next step. So what's your differential and immediate next steps? We are in the no fever, no hemolysis box. So you can see there's a whole list of transfusion reactions there. And our patient's already volume overloaded after infusion of second whole blood unit. The patient develops dyspnea, coughs sputum, crackles, JVD, hypertension, chest x-ray shows edema, and SpO2 is down to 85. And Taco and Trolley, like, whenever you're diagnosing Taco, you should always, like, rule out Trolley, always, because that's good clinical practice. It's more than that. It's just there's papers that write up that this is what should be considered on a differential. And when you're diagnosing Taco, you should really try to diagnose Trolley to make sure you can rule out Trolley confidently. The easy answer is like the patient responded to diuretics. Great. But what if it was a Taco and then there's an underlying Trolley as well? It can happen. I read about it. So just to let you know that Taco is the easy diagnosis. And the good news for Taco is that it's also very easily manageable because you can give diuretics and usually the patient will get better. So let's go over like a side-by-side comparison of Taco versus Trolley. So Trolley is usually an onset within 6 hours of transfusion, but then again, that's what the CDC recommends. Some institutions can use their own internal criteria for a Trolley. Taco is within 12 hours of transfusion, but then again, timing. If you're like, I love the CDC criteria because it's a great starting ground, and let's just kind of stick there. There's exceptions sometimes, and I'll leave it at that. Um, Oxygen saturations, it can be decreased in both. However, if you, not you, but if the patient drops um, less than 90 on room air, then you should also consider Trolley. It's in the diagnosis. But in this case, it's a Taco because the patient was hypertensive, JVD was elevated, and BNP was elevated. But just you can't really base your like if BNP is all you got and you got nothing else, you can't really base your diagnosis on just one lab. I've seen I've seen people do that, and I've read about that as well. So just it's a clinical situation here, and the chest X-ray you wanna look at the chest X-ray. Both will show bilateral infiltrates, no pleural effusions. Is there a response to diuretics? Yes. If there's a response, that makes your differential lean closer towards a Taco, and not a trolley. So that's important um, to keep in the back of your mind. So fever in taco is uncommon. In trolley, it's more common, but there's also hot tacos that's been reported. Um, Again, I spent more time on this because if we just use this criteria, we can arrive at a reasonable diagnosis. And case six management. So in this case, it's a taco. So case six, the transfusion associated cardiac overload management. The immediate actions is to stop the transfusion immediately, sit the patient upright. You can reduce preload and improve respiratory mechanics. Um, you can administer oxygen, nasal cannula, or face mask. You give IV furosemide. And if the patient improves with diuresis, you're kind of more leaning towards taco. If they're not improved, you're leaning towards a trolley. And then you want to monitor like the vitals, like oxygen, nation status. Where you get a chest X-ray, hemoglobin level, fluid balance review, and NT pro BNP when it's available. So case six pathophysiology of of taco or trolley. In this case, let's talk about taco. Taco, there's a two-hit mechanism of taco, and for example, patients with sickle cell anemia have already an compensatory expended plasma volume, which means they are already volume full even when severely anemic. They got one unit of whole blood is about 450 to 550 mLs and provides the same hemoglobin increment as 1 unit of red cell concentrates, which is 250 plus 350 ml. But whole blood nearly doubles the transfused volume, and whole blood transfusion increases taco risk. So the first hit is about a liter and a quarter of saline, and the second hit is 2 units of whole blood, which bumps this patient up by another liter. As you could see, it's pretty straightforward why this patient got a taco. Trolley pathophysiology is more subtle. You have donor anti-HLA and donor anti-HNA activate recipient neutrophils. It's a two-hit model where the first hit is there's pre-existing inflammation in a patient and it primes neutrophils and it slows their translate through the lungs and the microvasculature. The second hit is the transfused product with the donor anti-HLA and HNA antibodies bind and activate the recipient neutrophils that cause degranulation, increase pulmonary vascular permeability, and a lung edema. There's a graphic here at the bottom kind of explaining the process. I'll leave that for your review. Trolley management is, again, stop the transfusion, call the blood bank, provide supportive respiratory care. Oxygen is the first line of therapy. You can escalate to CPAP, BiPAP, or intubation because you want to protect the airway. And you want to protect the airway. Oxygen is first line, and then you can escalate to CPAP, BiPAP, or intubation or mechanical ventilation as needed. About 70 to 80% of these cases will need ventilatory support. Management of ventilation using ARDS principles. Severe cases may require advanced ICU support and rarely ECMO. Support hemodynamics. So you want to treat hypotension, hypoperfusion with fluids and vasopressors and avoid reflex diuresis early. You do not want to use corticosteroids routinely for suspected trolley. Evidence is limited and unconvincing with potential harm if ARDS is established. And that about wraps it up for this practice session. Cool.